Welcome, everyone, to another Journal Club. Tonight, we have with us a very special guest, Rick Gowenda, and he is a physical therapist and master of all things billing in this world. And this is our topic tonight. A lot of questions come up about how should we bill in the United States for vestibular care. So we're going to be covering some of that as well as an article that we chose on kind of the cost burden of recurrent vestibular vertigo in the United States. And these are kind of related topics. So we felt like it was an appropriate article since we do usually cover some sort of article with the Journal Club, being it's for journals. So we try to tie those things together. So if you could give us a little bit more of your background, Rick, that would be fantastic.
Sure. I graduated physical therapy school in 1991. Kind of grew up in the hospital setting as a staff therapist doing acute care, inpatient rehab, and then into outpatient therapy where I was a supervisor. Then moved to a level one trauma hospital in the city of Detroit where I oversaw PT, OT, and speech as the director. And kind of up in the upper management where I oversaw many other departments unrelated to therapy. So I did that until Christmas of '09. But then I started my consulting and seminar webinar company back in '03. So for 21 years now, I focus a lot on consulting, providing educational content via webinars and seminars for outpatient PT, OT, SLP on documentation, diagnosis coding, CPT coding, practice analysis, looking at your bottom line, a little bit of mergers and acquisitions, and then believe it or not, retained by attorneys when therapists and assistants maybe get into some trouble, either with their state licensing board or maybe the federal government. So that's probably the newest venture I've gotten into, and probably the most fun as you're trying to help therapists and assistants, maintain the license.
That is really interesting and certainly unique of a path, I would say, for clinicians. Most people, I think, when they graduate from their therapy school, they're thinking, okay, I'm going to take care of patients. But it's always interesting to me to see how we can kind of utilize our kind of broader abilities, critical thinking skills, and problem solving in different ways. And it sounds like you're really doing that. So I admire that very much. And I think it's very exciting.
Well, thank you.
So we're grateful. Yeah, no, absolutely. So we're going to go ahead and head into our topic. So we have plenty of time for our many questions that we had received via our very eager registrants for this event. And so if we could kind of pull up those slides, we'll get into those and cover some background for a minute. So I know that this feels like, oh, billing, why we're going to talk about vestibular anatomy, but I cannot start any journal club without just making sure everyone's on the same page, even as it regards to what are we talking about billing about? Because for many years, the vestibular world was not really something run by physical therapists. This is something that has kind of come along a bit later in the journey of physical therapy as a profession. And so, just kind of make everybody on the same page here. We're talking about the inner ear balance system. And because physical therapists often care about balance, it has made sense for us to kind of have this care as part of our professional scope. And so we care about the inner ear balance system and we care about the brain, which is kind of a master controller or computer, I like to say, of our kind of whole shebang, how we process information, how we keep our balance, how we operate our muscles. Very important structure. And this structure integrates information from the vestibular system and our eyes, and all of our joints have sensors that tell us where we are in space, bringing that information together to help us orient ourselves. And so when patients have problems with either the inner ear system or the brain processing centers, or both sometimes, unfortunately, one of the jobs of some specialty physical therapists is to help kind of work with those issues to hopefully reduce or eliminate dizziness, imbalance, those kinds of situations that patients find themselves in. And in particular, conditions that you might hear about include benign paroxysmal positional vertigo, the little tiny crystals that we all have in our inner ear that help us sense gravity. Sometimes they go in the wrong part of the inner ear, and this is a problem. because it can create, again, dizziness or imbalance or both. Then there's vestibular migraine, and this is a type of migraine that is less about headache, although that can be a feature, and more about dizziness and episodes of dizziness. And with that, often some other migraine features like light sensitivity, sound sensitivity, things like that. And then we have another condition that is a bit more rare than those first two, Meniere's disease, and that's an intermittent swelling of the inner ear. We're not really clear in the science as to kind of the true root cause. They're working very hard in research to sort that out. And so for each of these, they're episodic and recurrent. And this is a challenge for patients because it's like, not like I twisted my ankle, okay, we rehabbed it, now it's better. These are our patients that we could have coming in periodically to see vestibular therapists because, the crystals are out of place again, or, oh, I've had a flare of my vestibular migraine condition, or, oh, I've had a flare of Meniere's disease and now my balance is off again. And so these are patients that, as a vestibular clinician, you may see kind of repeatedly in clinics, which makes it a bit of a different challenge than, like I said, kind of a one and done, hopefully, ankle sprain that we rehab and everybody's happy at the end. So um, this means we can have costs, right? Repeated costs for these patients, kind of recurrently having to seek care. And sometimes the first part of care is the most challenging, which is, of course, getting that initial diagnosis. Am I dealing with BBV or do I have vestibular migraine? Not that the patients would even necessarily knows those are possibilities at the beginning, right? So this is a challenge for our patients. And so the article that we pulled utilized a database, and that was my first question for you, Rick, out the gate is, were you familiar with this database, and is this something that these kind of researchers would routinely look at when we're looking at kind of cost of services or kind of a cost or cost burden of a condition?
I mean, it could be. I mean, my disclaimer, of course, is I am not a researcher, so God bless the researchers. But again, obviously, I think research is very important, and you see a lot of it going on with the American Physical Therapy Association, as an example. We had that big paper come out earlier this year showing some of the main conditions, and if they get to physical therapy first, the savings that it can save, whether it be the Medicare program, commercial payers, etc. So I think this kind of data is extremely important to have. And then we need to know how to use this data as we're going to insurance carriers, trying to either get this reimbursed for by an insurance carrier, maybe also direct access first to physical therapy, uh, and get better reimbursement. So it's just we need to have the data, know how to use the data, and then get the connections with the insurance carriers.
Definitely a path there to communicate. I see that.
Mhm.
So this particular study I thought was interesting in that they focused on privately insured individuals and they focused on the age group of 0 to 64. And for a vestibular therapist, I said, wait a second, there's a lot of people with vestibular issues over the age of 64. Not that there aren't any that are younger, of course there are. But it was clearly a cutoff to me that seemed to likely surround Medicare, just a guess. I didn't explicitly state that in the article, I don't believe, but because that's a whole nother kind of potential way to look at billing and what would be reimbursed. Um, and if you could just maybe speak to what do I want to say? How diverse is reimbursement between private insurance versus like Medicare?
Well, you talking diverse in terms of the dollar amount?
Sure.
Yeah, it's diverse. You know, very diverse. Because obviously, if you've ever heard me speak before, I've always said, I love Medicare. You may not call the rules and regs, but at least you know the rules and regs, and they pay any per CPT code based on a fee schedule. And again, I'm not saying the dollar amount that the Medicare program reimburses you in whatever state/locality you're in is sufficient. But when you look at some of these other insurance carriers that are paying way less on a per
Mm,
CPT basis, such as Medicaid, or the one obviously it's so easy to make fun of nowadays is United Healthcare because they just keep doing foolish things, in my opinion. Uh, depending on what state you're in, there are some of you that have signed contracts that UHC is paying you $45 a visit, and that's all you get. And as long as your charge is above that dollar amount, you get 45. So I think when you look at how diverse it is, it's very diverse as you look from Medicaid to private commercial payers to, Medicare Advantage. I think it's still a huge issue. Many people are going out of network with Medicare Advantage because they're finding they can get those people to pay cash for the services. And I think what we're talking about here today, when you're looking at vestibular and BPV and vertigo and other related conditions, to me, that's a niche service that not many therapists and practices provide. That if you've been suffering for this for a while, even if you haven't been suffering for a while, are you more likely to go somewhere and pay cash versus if it's just a quote general orthopedic condition, you've got a wider variety of clinics or practices, hospitals to choose from.
Absolutely. No, that makes a lot of sense. So, this brings us to kind of what codes are used. So I'm definitely looking for some insight here. The codes that they listed in the article surrounded the diagnoses that you might see on a script. I know I have seen these. So a very common one is what I'll call kind of non-specific, this dizziness code, the R42. Sometimes a doctor might be guessing or they're certain, either one, that it is BPPV. You might see Meniere's code and you might see some migraine codes. So I don't know how familiar you are with these codes, and if not, that's fine. But I was just curious, do you know if it matters which code from a reimbursement standpoint? When does it matter? What should we be looking at as clinicians? Because I have definitely had patients who came in with, let's say, a BPPV code, and I'm finding very strong, consistent signs and symptoms that are fitting the migraine, vestibular migraine. I'm not finding BPV that day, although it's tough with BPV because it can come and go. So just because they don't have it that day doesn't mean they won't have it next week, which is tough. And of course, these conditions can coexist. In fact, migraine increases the risk of recurrence of BPPV as an example. So this is where it can get tricky. So is it safer to put kind of anything you think might be going on? Should you really just focus on what you feel like you really have found as a strong, yep, I think this is the diagnosis? Do I only put what the doctor put, even though my findings are not concurrent with that?
So I think you have about 6 questions in there. So I'll just start
I
talking.
know, sorry.
I'll just start talking.
Just do your best. Do your best.
No, I can do this in my sleep, so this is fine. Obviously, I'm going to start with, therapists need to understand ICD-10, and they need to understand what they call excludes one. And what excludes one is when you put a pair of ICD-10 codes on the claim that should not be together on the claim. And on this slide, you give a great example. So as you look at, H81.11 BPV right ear, and then you've got R42 is a dizziness. Well, R42 is considered and excludes one of H81.11, H81.12, H81.13. So if you code any one of those H codes I just said and R42 on a claim form, the same date of service, many insurance carriers are going to deny that because those codes should not be together because R42 is kind of considered part of the H81.11, H81.12, H81.13. So all you want to do is put one of those three on. Obviously, you try to avoid H81.10, which is BPV unspecified ear. Also, obviously, the reason I love Medicare is many of your Medicare contractors have what they call LCDs, local coverage determinations. And I know we're going to be talking about CPT code 95992 a little bit later, which is that canopy repositioning. And if you look at some of those LCDs for some of the Medicare contractors, as well as some of the commercial insurance carriers, in order to be reimbursed for 95992, a lot of those insurance carriers only reimburse if one of those three H codes are on the claim. Other codes may not get paid. So as you look at the other ones you had the H81.01 through, H81.03, whether or not payers will pay for one of those three codes, quote, by themselves on a claim form for 95992, most likely my experience is no. They're looking for that H81.11, H81.12, H81.13. So very important to kind of know that. And then if you submit a claim to insurance carrier, very important to look at the EOB when you get it back, explanation of benefits. Did you get paid? If you didn't get paid, why did you not get paid? And very important to look at those reason codes and what's a description of the reason code, because that will usually tell you, is it a diagnosis issue? Is it an excludes one issue? When you look at all the other CPT codes, I think we're going to talk about later, like therapeutic exercise, manual therapy, therapeutic activities, neuromuscular education, you have a little bit more leeway, I find, with using those CPT codes on the claim form with more diagnosis codes, such as the R42 by itself, perhaps the H81.01 or zero point 0.02 or zero point 0.03. So it really depends on the CPT code or code you're using, and then again the payer policy, because it can be one answer, for example. And again, Blue Cross is a great example. There's Anthem Blue Cross, there's Florida Blue Cross, there's Georgia Blue Cross, there's Illinois Blue Cross. So one Blue Cross could pay, for a certain diagnosis code and CPT code, and you're in a different state with a different Blue Cross, do the same thing, you may not get paid because of the payer policy. And that's what makes it so difficult.
Wow. All right. That's a lot to take in, but I appreciate it. So then I guess my follow-up questions is, if I have a patient come in and let's say I'm pretty sure they had BPPV yesterday, but they're like, gosh, I'm feeling a lot better this morning. It's weird. As soon as I made a point with you, of course, it goes away. Darn it. And they come in and they clearly have signs of vestibular migraine they're fitting the migraine criteria for that. I'm going to put that as their diagnosis, but I suspect they had BPPV and I'm concerned it could recur. Should I or can I put, let's say, the migraine code of some sort of G43, because I'm pretty sure they have vestibular migraine? It sounds like I should not put R42 in that case. If I want to put also the BPPV code, even if I have to put H81.10, because I don't know which side it was because it's gone now, but I think it could be back, because this is what happens with BPV. This is where it becomes really tough. So what do you think?
Yeah, unfortunately, to be able to put a diagnosis code on the claim form, it either has to be, say on a physician referral. So if the physician, put BPV right ear or BPV left or BP bilateral, as reason to come see you, you can do that based on a physician order.
Okay.
Now, but say they didn't do that, and they come to you, and as you describe, they may have had it yesterday or 2 days ago or 3 days ago, but now you're testing everything and it's coming out negative. You can't code BPV because they don't
Ah,
have BPV.
got it. Okay. All right. And then if they have it next week, when I'm just seeing them for balance, let's say for their vestibular migraine related balance issue, and then I find that they're clearly have BBBV, can I add it? Is that a thing?
Oh, sure. Yeah. I mean, there are going to be times when during an episode of care, you may add a new diagnosis that becomes present with the patient, or say you had a couple of diagnoses to start with, but now one of them has resolved and you're not treating it anymore. Technically, you take that then off any future claims going forward.
I see. Okay. All right. Yes, because because particularly BBV is our tricky one, because literally you can have it and then it's gone, and then 2 weeks later it could be back, and then a month later it can be back. Like, this is the challenge I find, at least with the particular BBV.
Yeah, and you hope during the testing you can bring it out and see it, so to speak, and then you can code it. But if you go through all the testing and there is nothing that says this person has BPV, then unfortunately you can't code something that isn't present.
Understood. Okay, this is helpful.
Mhm.
All right, so moving forward, looking at payments that were looked at in the study. And they were looking at big picture costs. So, not simply outpatient PT visits per se, but outpatient, inpatient pharmacy claims, all kind of net kind of cost burden for these different conditions that are episodic recurrent vertigo types. And they utilized the diagnosis codes. And they found that, unsurprisingly to me, I was not surprised at all, vestibular migraine had the highest cost, followed by Meniere's and then BPPV. And I'll just speculate that vestibular migraine, it's a chronic neurologic condition as migraine is defined in general. And so these patients, it's more management. Like you might think about patients with chronic neurologic diseases that you can be very familiar with, like MS or Parkinson's. These are conditions that do not typically go away, unfortunately. So it's really about a condition that we're going to be monitoring, managing, and that can be difficult to diagnose in the beginning, particularly because people worry about things like stroke or tumors, because vestibular migraine can have quite a few different symptoms as far as like, again, kind of like a visual aura. I saw like sparkling lights. What is that? Like these kind of vague symptoms that can be difficult. And unfortunately, vestibular migraine cannot be seen on imaging as it currently stands in science. So it's not like an MRI of the head is going to prove that you had it. So there are some folks who have multiple images because it's like, well, maybe the first time you had an MRI of the head last year, you just couldn't see the tumor yet. And I'm really worried I have a tumor. And can you check again? Sort of concerns, which are understandable because people don't want to miss the serious, right? The kind of, not that vestibular migraine doesn't have its own impact, but certainly tumors and strokes are the ones that we immediately worry about as things that could be more life threatening, we'll say. So Meniere's disease also, because it can be difficult to pinpoint in the beginning until the episodes become to the point where they have hearing loss, which is one of the requirements of the migraine. The Meniere's disease criteria, the diagnostic criteria. You need to have several episodes and then show low to mid frequency hearing loss. So that's going to take retest of various tests again. So we're seeing a lot of testing for these groups. BPPV, unfortunately, people sometimes think it's something more serious, and so they also can get imaged, even though positional testing, if someone who is seeing them would know how to do that, they could often find the BPV pretty quickly and then recognize that it was not something more serious. But this is difficult because not everyone has specialized vestibular training. When I say everyone, I mean, not all doctors, and that's okay. Like that's just the reality of primary care or emergency department care and that kind of thing, is not everyone gets a bunch of vestibular training. So this is where we have challenges. So the reality is that overall, there's quite a bit of costs, unfortunately, associated with these episodic vertigo conditions. And we as vestibular clinicians and specialists are certainly accustomed, again, to seeing these patients on repeat. The dream is really to see them sooner, because sometimes when they don't see specialists, I've certainly had patients that have had episodic dizziness for several years, and the people they were seeing were doing their best, but they weren't vestibular specialists, so they didn't necessarily pinpoint that it was even vestibular, because of course dizziness can also be from low hemoglobin or dehydration or all these other kind of mimickers, we'll say, because dizziness is just a broad sensation, right? It's not super specific. So they also, again, found that imaging was one of the main costs of these expenditures. It was not physical therapy, I'd like to mention. So if we want some argument perhaps to insurances to, instead of getting multiple images, we can try to see these patients, and not that they'll never need imaging, but perhaps, not repeat imaging to a point. Particularly BPPV, I think of those three, to me, is the best example of something where if you know how to do positional testing, you can pretty clearly identify BPPV most of the time. And then they pointed out in this article some regional differences, and they talked about some kind of theories about why the costs might differ, such as, were there enough experts in areas? And if you haven't seen an expert sooner, you're not going to need as much testing probably. versus, where you don't have as many experts, then you're having professionals doing their best, but they're running maybe what you might call later, oh, maybe that test was unnecessary sort of situation. And then also some possible regional differences with stroke and where you might see particularly younger strokes. I think it's kind of gradually becoming more clear that it's because someone comes in and they're 40 or 50 doesn't mean they're not having a stroke. Unfortunately, these younger folks can have strokes as well. And so we can't assume that because they're coming in with vertigo, oh, you're only 50, maybe it's just BPPV or migraine. No, we do need to look for strokes. So that's kind of the other challenge is you don't want to miss again these strokes. And so knowing how to do things like the HINTS exam, which is a whole nother topic, can decrease unnecessary imaging in the emergency department as well. We've talked about that in past journal clubs, but just understanding that there's an ongoing goal for education and improving the quality of vestibular assessment and care for sure. So the conclusion of this article was that there probably is some extraneous imaging and testing that's being done that's not always necessary for patients. And if we can get more clinicians to become experts, that would be fantastic so that we can help these patients to get the best assessments more efficiently so that we can really get them the next best step towards treatment for the correct condition that they're dealing with. So we have a couple other questions related to billing that come from this article and also some questions that we got from our registrants. So one thing that has come up in questions, so I wanted to kind of maybe have your help defining it because this is a newer kind of phenomenon, is this remote therapeutic monitoring. And there are several apps out there and kind of services, you'll say, that are coming out in the vestibular world. And I've listed some of them here on the right hand of the slide that they're kind of saying, hey, you can bill more using our app because you can use this remote therapeutic monitoring codes.
Mm-hmm.
So could you explain, please, Rick, what is remote therapeutic monitoring and what's kind of the necessary elements to make it billable and allowable?
Yeah, so remote therapeutic monitoring, RTM, came out January 1 of 2022. And the Medicare program actually does reimburse for remote therapeutic monitoring if done by PT, OT, and SLP. And the reason I say Medicare is we love when Medicare does things to help outpatient therapists because typically if Medicare reimburses for something, it helps other insurance carriers also decide to reimburse. So because Medicare began reimbursement for this in 2022, we do see, some other medicine, greater than 50%, we'll just go that way, I'll go conservative, the Medicare Advantage and the commercial payers also paying for remote therapeutic monitoring. What remote therapeutic monitoring is, it's an adjunct to in-person therapy visits, whether in-person is your face-to-face in the same building or, in-person via telehealth. So RTM is not the same as telehealth. RTM is not a visit. But the goal of RTM is to kind of stay better in touch with the patient, to keep them engaged, doing what you want them to do at home and following them maybe more often. As you know, you may see patients 2 times a week, we just say Monday and Thursday. But Tuesday, Wednesday, Friday, Saturday, Sunday, they're kind of on their own. You hope they're doing what you want them to do. You don't know if they're doing what you want them to do. It's the honor system, etc. Well, the use of remote therapeutic monitoring is using digital technology to set the patient up on a home exercise program that they can then log into the app or a medical device. So the device must be either a medical device or software as a medical device that meets the definition of a medical device per the FDA, does not need to be an approved medical device by the FDA. So, the patient, signs into this app or into this medical device, however many times you tell them to do so a week. They complete whatever exercises you've given them in a home exercise program. If you want them to document their signs and symptoms every day. You do that. A lot of these things patients can type in. The therapist on the back end, can then log in to that patient's account, and they can check to see, is the patient doing the exercises that the therapist prescribed? Are they doing them correctly? They can answer any questions the patient may be having, texting the patient, etc. That time the therapist is in that patient's account, check and see how they're doing, updating the home exercise program, responding to them, etc. Usually most of these apps are going to keep track of how much time that therapist is in each day. And I think you have these codes maybe on the next slide or coming up. You see CPT codes 98980 and 98981 at the bottom there of the slide. And that is the remote therapeutic monitoring management services, where the therapist is staying in communication with the patient, updating things, etc., and having at least that one interactive communication. So I'm trying to teach RTM that's about an hour and a half into about a 6-minute thing here. The thing is, when you're looking at, say, BPV and some of the other conditions Helena has mentioned, basically you're going to be limited to 3 codes. 98975 is the initial setup with the patient with that medical device you're using, or that software as a medical device that you're using. So you're getting them set up with an account, maybe showing them how to use it, how to input the data, telling them what to do, etc. That's going to be the 98975. That as long as in the first 30-day period, that patient actually logs in and does what you want them to do 16 of the 30 days, you can then bill 98975. 98980 and 98981 are billed at the end of a calendar month based upon the amount of time you spent analyzing the data that's being transmitted, responding to the patient via email, text, calling the patient, updating, whatever you need to do. There's a certain amount of minutes you have to do each month to be able to bill 98980, and then even more minutes to get to 98981. So we're seeing this used a lot over the first almost 3 years in the MSK world for the musculoskeletal. But obviously we can do it for other conditions. You're just going to be limited on which CPT codes you can bill.
I see. All right, that's really helpful. So, these apps that I'm familiar with, so Virginius, for example, and TheraVista, they're both somewhat similar in that they're having some sort of gamification, we'll call it, of vestibular exercises, traditional, maybe kind of VOR times 1 that a lot of folks are familiar with, where you're having to move the head back and forth and focusing on some sort of target. But they're doing it on an app where there's like a dolphin that you're trying to move through a maze, or some sort of where you're kind of make it more interactive and perhaps kind of improve then that adherence. So you mentioned kind of a certain amount of time frame that you're spending. So does that make this a timed code essentially for like the 98980? Oh,
The tongue twister. Yeah.
oh my
So,
goodness.
98980, you have to have at least 20 minutes of remote therapeutic monitoring management services that month.
Got it.
So, it might be 2 minutes and 12 seconds on July 1st, might be 3 minutes and 14 seconds on July 5th, 47 seconds July 7th. It just has to add up. And you have to do at least 20 minutes, the whole 20 to go 98980. To build then a unit of 98981, you got to have a whole 40 minutes in that same month. So if you did it for a whole 40 minutes, you'd have 1 unit of 98980, 1 unit of 98981.
Understood. And then, of course, the question come up, what might be the range of reimbursement? Like, what am I looking at here? Do you have any sense? Is it like usually $1? Is it usually like kind of more like a typical timed 15-minute code of like, I don't know, $30? Like, do you have any sense?
Yeah, I mean, obviously I can give you the Medicare rates because, Medicare publishes their rates. So this year in 24, 98980, the national average is around $47 to $48. So depending where you're at in the country, you may be higher than national, lower.
Got it.
98981 for the second 20 minutes, roughly 37 to $38.
Got it. Okay. Perfect. No, this is helpful because I think people will ask and kind of wonder like, is it worth it, right? Like, should I be using these apps? Not only I want to help my patient care, but I don't want to do it and then spend that 20 minutes and get a dollar, right? Like, this is the constant challenge that you're likely aware of.
Yeah, I mean, do I think it's worth it overall? I do. Obviously, I've done a lot of consulting in RTM since the codes came out. I think what you have to ask yourself too is the companies you have on the screen we're looking at right now is, how are they charging you or how are you paying
Hmm.
them? And that's what you have to look at. And then are you paying them regardless of whether you get to 20 minutes or 40 minutes? Or is it, have they structured it where we don't get paid if you don't get paid? And of course, then you got to make sure it's all legal, because you don't want to do any Medicare thing wrong in terms of how you structure a contract.
Right.
So I think that's what you have to look at. Where if it's a shared risk between you and whoever you're using for the app, nothing to lose. Whereby if you got to pay but you may not do what you need to do to get 20 minutes or 40 minutes, or the patient doing the 16 days of 30 to get 98975, yeah, you're going to be paying for services that you're not getting any reimbursement back. Also what we're seeing on at least on the MSK side is you just can't also look at this as RTM in a silo, because I don't know how it is with the BPV and the vestibular patients, but typically when you look at the orthopedic population, by the time that patient gets to the third or fourth visit, there's a huge drop off. People just don't come back. So what we're doing with a lot of large practices on the MSK side is, okay, let's look at 100 patients that are not in RTM and 100 patients that are in RTM. And what we're seeing, and let's just say without RTM, you had, they say only really about 30% of the patients complete their plan of care. With RTM, with some of these larger practices, instead of 30%, it's 44, 45%. So not only are you making money off RTM, but you're getting more patients to complete the entire plan of
Mm.
care. Also, instead of having 60% drop off after visit 4, is it only now 40% after visit 4, and maybe some are dropping off after visit 6 or 7. So you're seeing better compliance with patients also attending therapy and making your ROIs better that way. Also, if you can get your patients better quicker and you've got great data and outcome data, can you then use that data to go back to these commercial payers who renegotiate your contract? So I know I'm going off topic here, but I just don't want people to think it's RTM as in a silo. There's many things to look at to see how it can benefit you. And I think it can work with the patients that we're talking about here today.
Understood. Now that makes a lot of sense. And I think the patients that these apps, this monitoring would really fit well is not so much your BPPV, which in most cases we're able to clear that in 1 to 3 sessions. So I'm feeling good about that group
Mhm.
as not needing ongoing monitoring in that sense. But there's certainly a good chunk of patients with vestibular migraine, with Meniere's disease, with
Mhm.
any sort of unilateral or bilateral hypofunction, where they're kind of what I'll consider more your longer term patients. They could take anywhere from a couple months to, unfortunately, several months. Concussion might be another group. So you kind of have these patients that, kind of more complex neurologic or fluctuant conditions where they need ongoing
Mhm.
visits and monitoring. This could make sense. So I think it's a good thing to think about for our clinicians out there. If you're not familiar with this or haven't tried using it and want to explore, I know TheraVista, they do free trials sometimes. Vertigenius is newer, so we're going to see what they have available. They're out of Ireland, which doesn't mean we can't use them. It's just kind of being aware that they're kind of just coming out in the U.S. market. So do your research. Certainly, most of these places or apps will give you like a free demo, and so you're able to kind of get a sense. And they should be able to give you concrete examples of, well, how are people billing? What has that been looking like? because I think that's, certainly an onus on them. And I agree with you to kind of, give you a good translation of what this could look like for your practice.
Mhm.
So awesome insights. Okay. So now we're going to dig into some codes that come up, these CPT codes. So the first group of codes I wanted to talk about is what are considered the VNG codes. So these codes are historically billed by ENTs and audiology groups. Sometimes other physicians, like a neurologist, for example, might have the equipment and the appropriate training to do these tests as well. So it's not exclusive to ENTs or audiologists per se, but historically it's certainly been kind of what I'll call certain disciplines. And physical therapy has not historically been in that group. So the expectation is even if you had all the equipment and taken all the training, my understanding, and this is where I'm going to look to you, Rick, is that it's not common that these would get reimbursed for a physical therapist. Any input on that?
Exactly what you said. So, obviously, who you said it's done by is typically who it's done by. So, unless what you have to look at is as a physical therapist is number one, are you trained to do what we're talking about here on this slide? And I think also the next slide might be some codes too, if I'm not mistaken.
Yep.
Are you trained? Also, is it within the scope of your practice? So, obviously, both those answers have to be yes. Here's the part that PTs don't like is yes, yep, Rick, I'm trained to do this. Yep, it's within the scope of my practice. But can a payer decide which CPT codes they're going to pay for and by which discipline? And the answer is absolutely yes. So even though you may be qualified to do it, it's within your scope of practice. If a payer says it has to only be done by this discipline, this discipline, this discipline, and we don't reimburse it if it's done by physical therapists, that's their policy. We know Palmetto, who is a Medicare contractor, they have what they call an article on vestibular function testing. And basically they say it's either a licensed audiologist, we've heard, who under orders of a physician, or another licensed professional who can do medical practice. So that'd be like a physician assistant, nurse practitioner, somebody like that. So again, it's one of those battles, whether it's APTA at a national level or your respective state association for your state payers to continue to lobby to try to get payers to, recognize physical therapists as qualified healthcare professionals to do these codes and be reimbursed.
Yeah, and I think it's one of those things that if you look through history, and you can probably enlighten more than I could, but codes have evolved as to who has been allowed to bill them, and sometimes practitioner disciplines have been added, and sometimes they've been taken away.
Mhm.
Um, and it's kind of like you said before, what Medicare does, most of their payers follow, and so if Medicare is not saying it, then the likelihood of whatever Illinois Blue Cross saying, "Oh yeah, we think physical therapists are, qualified to do this," is less likely. We'll say, not never, but so I think it's tough because vestibular is also a niche within physical therapy.
Mhm.
So I'm not saying that this would never be something that could be on the table because anything's possible, but I think it's a little more difficult to perhaps get the APTA, or if we as vestibular clinicians, all y'all out there, wanted to band together and say, hey, like we do feel like we'd like to be recognized for kind of getting to that point of being able to do this testing and having that equipment, then it's still a question of kind of volume often. If you would agree with that, Rick, or I don't know what your thoughts are on kind of what those, if you've seen any code in the past get added, what usually kind of has to happen there, like dry needling or something? I don't know.
Yeah, what I was going to say, I know this code's coming up, and we already mentioned it. 95992 canopy positioning. That code actually came out in 2009. And in 2009 and 2010, the Medicare program did not reimburse for that code. And because of that, nobody reimbursed for that code if when done by PT. In 2011, because of APTA and other professional associations, we got CMS to change and they made that what we call an active code in 2011, and Medicare began reimbursing physical therapists for 95992. Because of that, then other payers followed. So if you look at a lot of your commercial payers and work comp and maybe not so much Medicaid, but a lot of your commercial payers and Medicare Advantage, they now pay 95992 because of the work of APTA and others to get Medicare to pay for it back in 2011. I also agree with what Helena said. It's going to take persistence. And I think a great example are those, diagnostic services that, PTs were doing, the EMGs and all of that. And, weren't getting paid by the Medicare program for the EMGs, et cetera. But again, because of the work of APTA and state chapters, et cetera, now there's quite several codes that are reimbursed if done by a PT with the proper training in the EMGs. And I know we're also asking CMS to add additional codes for 2025. So I think it's just got to keep on working. And unfortunately, it takes years sometimes
Right.
to achieve what we want to achieve.
Yeah, that's a good point. So suffice to say, everything on this slide at the moment, odds of reimbursement are low, and perhaps with time, this will we'll be able to establish as a profession and as a subspecialty professional group that this is something that could be pushed forward at some point. So just keeping that in our hat for now, and let's look at some codes that we're pretty familiar with. So everyone, I would say, who's a physical therapist is most comfortable with 97110. We know that that's something we're allowed to use. Yay! And so it's easy to think of exercises that I can give for somebody after concussion. I'm going to strengthen their neck, that I can put under 97110. That's fair. That's reasonable. And again, most of these other codes similarly so. So what I wanted to focus on this slide, if you're comfortable with this, is you kind of alluded to 95992 and any kind of additional insights beyond what you've already stated there. And then 97750. I'm aware of some clinicians who are using equipment, particularly infrared video goggles, as part of their assessment, not during the initial evaluation, but on a subsequent visit. So I have someone with BPPV on initial evaluation. Definitely they have it. I do maneuvers, and then they come back to me, next week or whatnot, and I want to reassess them and see if that BPV is cleared, or is it not quite clear, or did it convert to the different canal or whatever. So I'm going to get those goggles out. I put them on the patient. I do some different testing. I know 97750, some people have told me, oh, that's only if you're doing like a work assessment. So what light can you shed on that one first, and then we'll get to 95992 in a minute.
Yeah, so 97750 is a physical performance test or measurement. And again, as you said, the Medicare program does not reimburse for that code on the same day as a therapy eval, because really whatever test or measurement you're doing, it's part of that evaluation. But if on a different day you do a physical performance test, PPT, yeah, this is a code to use. It's just not for a functional capacity eval. So, obviously, I think if I gave some common names of the Tenetti time get up and go, 4-square step test, Purdue pegboard test. If I age myself, for those of you who may remember the Lido, or there's a Biodex or a Cybex where you're testing involved extremity strength versus uninvolved extremity strength. So the key you always have to ask yourself is the patient physically participating in the test or the measurement? And if you say yes, to me, that can qualify as a PPT, where questionnaires are not. And I know you say, well, Rick, they got a pen and they're circling. That's not actively participating. Okay, so questionnaires, no. But I think some of the things that Helena mentioned would be a yes. Now, with that said, 97750, it's a 15-minute time-based code. The time that counts towards at each 15 minutes is a time it takes you to administer the test and analyze and interpret the results with the patient present. The time to write the report is not billable time. An assistant can administer the test under the direction of a therapist, but they cannot analyze the results, interpret the results. That has to be done by a therapist. Also, keep in mind, Helena, you gave another great example here where you do the test today. Might have the patient come back in a week or two and redo the test. You also have to look at how often does an insurance carrier reimburse for 9770,
Mm,
because I've seen some insurance carriers say, they'll allow maybe 2 units every 30 days. So you want to check on that as well. Where again, I love Medicare. Medicare does not limit it. If it took you 4 units and you want to do it once a week and you could support it via documentation, Medicare would pay. And again, if they're questioning why you bill it so often, they would just request the records. Other payers may limit how many units they'll pay in a given day and how often they'll pay for 97750.
got it. That's really, really enlightening. That's perfect. Okay. So that then brings us to the 95992. So I know we have a couple specific questions about that in a slide or so,
Sure.
but in general, any additional insight on that code that you want to kind of just put out in general for people to be aware of, timed, untimed, things like that?
Yeah, this code is unique. If you read the description, it's actually what they call a per day code. So it doesn't matter how many times, how long you spend doing canth repositioning or how many times that patient comes to see you that day. For example, I come in to see Helena in the morning. She does her techniques. I leave. For some reason, I come back at 1 o'clock. She does the techniques again. I leave. I come back at 4 o'clock. She does it again. It's just 1 unit because it's the same day. I know we're going to come up these questions, because the biggest issue, I think, from a payer perspective is billing 95992. It's an untimed code. But on that same day you're doing the CMAT, the EPLI, are you doing other interventions described by therapeutic exercise, manual therapy, neuromuscular education, and therapeutic activities? And I think you are at times. Uh,
Definitely.
so again, I love Medicare because Medicare will pay for those other 4 codes I just said on the same day you bill 95992. Now, if you bill any of those other 4 codes on the same day as 95992, you're going to have to append modifier 59 to those other 4 codes on the claim form. And also, documentation of the medical record would clearly have to demonstrate, clearly show that 95992 was done at this time and whatever other codes you build were done at this time, a different time. The issue I'm sure your listeners, are experiencing are those other payers that say, Rick, we follow Medicare. Okay. And this is Humana, this is Aetna. We see this with some Blue Crosses. So now you do 95992 and maybe one or two of those other 4 codes I mentioned. You put modifier 59, you don't get paid. You appeal, you get denied. You appeal again, you get denied. So we're seeing payers say we follow Medicare, but they're truly not following Medicare. And I think if it's a national payer like a Aetna, United Healthcare, Humana, that's when I think you want an APTA note, and you can email APTA at advocacy@apta.org, whereby if it's a state issue, like your state Blue Cross, your state Medicaid, maybe an insurance specific to your state, then I think it's working with your state association. And then also, don't be afraid to get your patients involved because I think, obviously people always ask, well, can I go to the insurance commissioner? Well, you can, but no offense, they don't care about you, the practice owner. But if you get your patients to go, saying my therapists are not being paid for the services they're giving us, and they should be getting paid per the policy, can you do that? Can you have your patients go back to their employers, the HR department, and let them know what's going on as well? So unfortunately, it's going to take some work on your part and or perhaps the patient's part to again, try to get change.
That's a really, really good thought and good motivator. 'Cause I can certainly speak for my own self, and I'm pretty sure I've heard this from other clinicians in the vestibular realm. Not that you can't be very powerful in the MSK realm or the pediatric realm or any other realm, but I will say that the patients can be very amazing advocates because they're like, oh my gosh, like you're a life saver. Like I was like spinning and throwing up and couldn't go to work. And like, especially with BPV, it's like the most motivating thing. You feel like a miracle worker when you're like, oh, I maneuvered you. And, that's clear. Now, not every vestibular clinician is that straightforward, but I think we still can be, really help our patients' quality of life. And sometimes they are willing to go to bat. So I think that that's a good opportunity that we should think about.
Yeah.
We're going to go right into our official questions here now after all that good background covering of material. So, as somebody who said, I work at a bounce center in New York, our clinic is mandating the use of 92549 for PTs. And I was wondering if you could just kind of reinforce what you maybe said earlier here.
Yeah, I mean, obviously, one word that stuck out was mandating. That would be a concern for me when someone is mandating you do something. Because obviously, you only provide a service when the patient needs that service. That's number one. When I saw this question, and then number two, unfortunately, I think Helene and I already gave you the bad news that yes, you may be qualified to do it. The vast, vast, vast majority of insurance carriers are not paying for the 92549 when billed under a PT plan of care.
Yep. All right. Answered that question. Check. Next question. I am wondering what solutions can you recommend to address repeated denials? And you sort of touched on this for 95992 when billed in combination with another PT code, therapeutic activities or neuromuscular re-ed. And this particular person just wanted to let you know that they were in Texas.
Yeah, so this is going to be, quote, Texas Blue Cross. So I think it's what you and I just discussed. I think it's probably Texas Blue Cross saying, hey, we follow Medicare's NCCI edits. So you got this provider here in Texas with Blue Cross. They're doing the cancer repositioning, doing whatever other functional activities, whatever other, proprioceptive
Balance training.
balance training, coordination training, putting, I'm sure, modifier 59 on 97530, 97112. My opinion, when they get the EOB back, it's not being paid, with the reason code being it's a bundled service. So again, you're going to try to appeal to Texas Blue Cross. My opinion, based on experience, you're probably not going to get paid. So again, I think it's, going back to the Texas PT Association, can they intervene and try to, work with this? If you do appeal, obviously, I think you should print off the Medicare NCC audits that show that 97530 or 97112 in this example, Medicare would pay for those two codes the same day as 95992 with modifier 59 and say, hey, you say you follow Medicare's NCC edits. Here's the edits. I billed it correctly. My documentation demonstrates I did these things at separate and distinct times. You need to pay me. And you go through that appeal process. If it doesn't work, again, using your patients as advocates and or trying your, in this example, the Texas PT Association.
Yeah. And I think you're pointing out doing it at separate times is perhaps helpful. So I'm thinking, and I don't know if this would help or not. The way that my EMR is set up, it's like, oh, here's what we did. Okay, so I did this maneuver, 2 rounds of the modified Epley. Let's say I cleared left posterior canal. Looks good. All right. Well, they were still kind of off and feeling weird. So I'll often give some combination of gait stability exercises and some basic balance just to help. I call it the brain reset a little bit, because we know from lots of literature and research when BPPV has happened, it does actually affect the brain, because the brain is a learning machine. So it's getting bad input. It's unfortunately learning from that. And so then we have to kind of get our balance system back on track. Recalibrate, perhaps, is the term I often use too. So this is where I would want to spend a little time, if the patient's tolerating things okay on, some of those activities, billing 97112. So if you put like, okay, from 10 a.m. to 10:15 maneuver, and then 10:15 to 10:45, balance and gait stability exercises, whatnot, listed that out and kind of have that in the note with the times. I'm just curious. I don't know if it would help. I'm just saying, like, mine isn't really time set that way. It's just like, I saw this person for an hour and here's what I did in this hour. So if I like laid out the timing, I wonder if that would help or not.
Yeah, I mean, obviously, when I teach this around the country, one of the ways I say is what you just said. So from 10 to 10:13, cancer repositioning techniques of boom, 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 boom. from 1014 to, whatever, 1045, focused on neuromuscular education techniques of boom, 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 boom. That's one way. That's probably the best way, even though I know you're making up the time because you have no clue what time you did what. Also, might you do cancer position from 10 to 10:05, and then maybe some neuromuscular education from 10:06 to 10:09, back to cancer positioning 10:10 to
Yeah.
that stuff. So I get that. So another way is, could you say, cancer repositioning of boom, 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 followed by and
Yeah.
then neuromuscular education of boom, 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 followed by therapeutic exercise of boom, boom, boom. So maybe by using the words also followed by and then
Mm,
can show separate and distinct times as well.
smart. Yeah, that's a good point. So yeah, it's kind of annoying, right? But we just recognize that I call it jumping through the hoops. Sometimes you have to jump through the hoops a little bit and kind of figure out what's going to best capture, convey, and make clear kind of what's happening.
You should have seen all the hair I had before I got into compliance. This makes you pour it out.
I get it. That makes total sense. Okay, really helpful there. Let's talk about this next question. Looking
Sure.
for guidance on multi-layered diagnosis and coding. And this is a bit overlaps some of what we talked about before with someone with BPPV. Maybe I even do find it that first session, but they clearly have, well, we call it triple PD, I think is what they're referring to here. This is a persistent postural perceptual dizziness. There's no code for it. So often I will use the vertigo of central origin is the ICD-10 that I have used. Because basically, if it's the brain, I use that because I'm like, all right, something with the brain making us feel dizzy. How should we utilize these codes? And how can we use CPT? Again, I think this is kind of the double kind of. We just talked about this, the 95992 and the 97112. But let's just talk about the ICD-10 part. Is it acceptable to list multiple diagnoses that concurrently often overlay in these patients, whether they have, clear BPPV, but clear vestibular migraine? Again, these could be risk factors, et cetera. Thoughts on that is ICD-10 piece of that.
Yeah, I mean, you can put multiple diagnosis codes on the claim if it's confirmed by a physician's order and or your eval, your testing, your
Okay,
findings. Just need to make sure that the ICD-10 codes on the claim, none of them are and excludes one of each other.
got it.
There's the other thing I didn't touch on that is excludes two. So sometimes
Oh,
when you're looking at the ICD-10 diagnosis codes, under one of the codes, you'll see excludes two, and then it'll list some codes. Excludes two means those codes are not part of the code above and can be on the claim with that code.
okay.
I got you thinking.
I'm really
You
struggling here. So
dizziness.
So if I am not sure, okay, so I'm like, okay, I know this person has BPPV. I know this person has vestibular migraine. Um, they fit the criteria, they have findings, whatnot.
Mhm.
And how would I know if those were an excludes one or excludes two? Where would I look for that information?
You look for it in the ICD-10 coding manual, the coding book.
Got it. Okay.
So, and just so CPT codes are effective January 1 of the calendar year through December 31, where ICD-10 codes are effective October 1 of a calendar year to September 30th of the next year. So, since we're recording this on September 24th, in a week from today, we will now be on what they call fiscal year ICD-10 2025.
Okay. Yes, because it's
And you
not
can get
confusing
this,
enough.
and you don't have to buy the book. The ICD-10 codes are on the CMS website. So, and even if you don't do Medicare, you can download these because all payers use the ICD-10 codes. And you can,
Got it.
what I tell you to do is an alphabetical list you can download and a tabular list that's broken down by chapter. So again, a lot of the codes that we're talking about here today are going to be in the chapter that starts with the letter H, as in Harry.
Perfect. Yes, absolutely. All right. Question number 4. Please help clarify coding in acute care. We get patients referred from other PTs, see them as a treatment visit, but really we're assessing what's the correct way to bill when a new order has not been generated by a doctor. Familiarity with this issue? What do you think?
We'll have fun. No, I always joke with these people. Nobody cares. And what the reason I say that jokingly is if it's truly acute care inpatient, nobody truly cares because from a payment perspective, you're not being paid on a per CPT code basis
Mhm.
and all that. And in true acute care, you reimburse under what they call DRGs,
Right.
diagnosis related groups. Where you do care and or your say hospital would care is if that patient for some reason did not meet the criteria for an inpatient admission and they got flipped from inpatient to outpatient, well, then it's just no different than them coming to your brick and mortar clinic or you going to their home to treat them. Obviously, the doctor can give you an order, or can you give a treatment therapy diagnosis based upon your physical therapy evaluation?
Okay. So let's do a scenario just to make sure it's clear. So a person comes in the hospital with vertigo and they put them on the observation unit.
Which is outpatient.
Uh, yes. So this is, I worked in acute care, so I'm familiar, unfortunately, with the challenges of this.
Yep.
And so I go in to the OBS unit to see a patient with vertigo because often the doctors are not as familiar with vertigo in hospitals, which is, they know how to rule out stroke and they're not going to know, how to treat BBV necessarily. This is my experience at the hospital I was at. So I go in, I would evaluate. I would do an evaluation. Now, this patient may or may not have been seen as an outpatient. I don't know, but I would just evaluate. And then if I did treatment, like say I would be positioning, I would bill as such. I don't know what diagnosis was being put because that's usually the hospital, right? So I don't know if they're putting H81. That's a good question. Hmm.
Yeah, so again, I agree. If that patient stays quote observation, gets discharged home, most likely your hospital's billing that out as outpatient therapy as part of the claim. So yeah, then you're going to do your PT evaluation code, whether it be low, moderate, high, and then whatever treatment codes you may have done that day. Again, every hospital unfortunately is different how you do it. I know when I was in hospital administration or when I was treated in the hospital for the 12 years, we could give a treatment therapy diagnosis into the system that the coders, could either, the coders could take that off and put that on the claim to help support what we were billing. What your hospital system is doing, unfortunately, Helene and I can't answer that question because every system is different and you've got
Right.
Epic and Cerner and some of the other EMR systems, but it'll just also what your coders do. Some coders will not code off of a therapist evaluation. They will only accept what a doctor wrote on an order. Others will use both. So it just depends.
Right. Now, the scenario that I now suspect they're perhaps alluding to, just to kind of be complete on answering the question, is my colleague goes to see a patient because the doctor wants to figure out if they need to be sent home or to a rehab or something
Mhm.
because it's an older person who was living alone and they're coming in with balance complaints. And then that colleague says, "Oh my gosh, I'm very sure this patient has something vestibular, but the only person here on staff that is vestibular trained is Helena. So tomorrow, Helena, can you see my patient in such and such room, whatnot, and work with them?" Well, the
Mhm.
reality is, of course, I'm going in and doing a vestibular assessment because they're just like, "Oh, I think it's vestibular," right? They're not saying, it's definitely this or that. So I'm going to do an assessment and probably I'll do some treatment if it's BBV, or if I think it's not BBV, I'll probably at least give the gaze stabilization exercise. But more of my time is being spent assessing. So you're saying it probably doesn't matter at the end of the day because acute care, whether I'm going to bill for my time. That's how I would see it. So I would just say, maybe you do 97750, maybe you just bill some 97112, but you bill for your time that
Mhm.
you spent assessing and treating and call it a day. And then that's going to fall under their DRG anyway. Is that accurate?
Correct. And again, when I read this question, it's interesting because whoever wrote this question is saying they get patients referred from other PTs. So that's where I'm kind of confused as we're talking about acute care. So I'm not sure if she means you got a PT that was seeing this patient truly in acute care,
Right.
did their therapy eval in acute care, but now they go, Helena, I think you may want to go see this person because I think it's not for me. So I think they're talking acute care. I truly do.
Yeah.
And I think it's just like Rick did this eval. This is not Rick's area of expertise. Helena, you're in.
Yeah.
I'm out.
Yeah.
But yeah, I
Got
mean,
it.
whether it's inpatient or outpatient, I still think you quote bill whatever you would bill, you document everything the same, and let the people on the back end in the billing department and all that figure it out. And if it's a
Yeah.
true inpatient acute care, you're not going to get paid anything extra. It's just the time you spent taking care of this patient or whatever, it's going to get figured into the hospital as additional expenses to care for that patient. If they get flipped to outpatient, yep, they'll bill separately, the therapy evaluation, any of the treatment codes you did.
Got it. All right. Almost done our questions here. How should you bill for time when a patient returns for a follow-up visit for BPV? You're going to reassess as you should, and you don't find any residual BPPV. So there is an option to do 97750, which based on what you said earlier sounds completely legitimate. I don't think you could bill for a repositioning code if you don't do repositioning. Agreed?
Patient transfer, yeah. Again, now this one, when you positional testing, I can't say it's 97750 or not, because if it's just you, the therapist, doing everything and the patient's not physically participating in it, then I would,
Well, they lay down, they roll with you, they participate.
that I would not say is 97750.
Okay.
Uh, so then, obviously when you get 95992, again, you're saying it's quote cath repositioning, such as Epley and the CMOT. So I think, depending on what else you're doing that day, because again, it's a tough one for me to answer because, yep, you do the assessing, everything is negative. And I guess maybe I'll put this back to you, Elena. If, how
Mhm.
long would that take you? And if everything's negative, you just say, bye-bye, Rick, you're done? Or would there be other things you would do? Because if there's other things that you would do, that's
Yeah,
when you spend assessing, those minutes would just get kind of added into whatever else you ended up doing that day, whether it be
got it.
the max, the manual, the therapeutic activities, and so on. I can't imagine you spend 2 or 3, 4 minutes or whatever it may be. Okay, you're good, Rick. Bye-bye. Thanks for driving an hour.
Yeah.
So
Yeah. That would be rare because my rule of thumb is if the patient is very sure they feel better and they're pretty physically able, we'll say, I'm telling them, don't come back unless you feel like it's not quite clear, and then call and we'll get you on. Whereas if I have someone who clearly had balance deficits that I am sure extend beyond the fact that they have BPV, I'm gonna, not to be ageist, but perhaps like an older patient who's, in their late 60s, and I can see they have some, overall balance issues that I don't think are just because they had BPV that day. I already know I want to keep them on for a bit longer after I clear the BPV to do some kind of focused balance work for usually a couple sessions. And that's actually recommended in the literature as well.
mhm.
So,
Yeah,
yeah, so that case, yeah, I'm going to assess them. And luckily, most of the time, it doesn't take that long to assess unless they have some significant mobility issues. But
mhm.
at that point, my suggestion could be billing 97530 therapeutic activities, because chances are you're working on, okay, I want you to reach your arm over, I want you to bring your leg over. So you're working on rolling, you know, as part of that assessment at that point, if they're not able to move easily. If it's someone who can move easily, rechecking for VPV takes like a couple of minutes.
Right.
If that makes
Even if they can move easily, and let's just say it took 3 minutes, okay? And now let's just say you go and do, I'm just gonna keep this simple, 36 minutes of a combination of, Therax and neuro and manual. But that 3 minutes of you assessing played a part into you deciding what to do then that day. So the mistake I think people make is they think, well, it's only 36 minutes, maybe it's only 2 units, but I would say it's 36 plus the 3 is 39.
sense.
and that would be the third unit, say if this was a Medicare patient. So that assessment time that you're assessing to find out, okay, yep, Helena's quote normal. So I don't need to do this today, but I still need to do this, this, this. Those minutes are quote not billable. They're just going to get added into the other things you're doing that day that may or
Got it.
may change how many units you bill.
I think that makes total sense. All right. Almost done our questions. What do you think patient education, I bet this comes up a lot,
Mhm.
best falls under? So let you answer that.
Yeah, I mean, I think it's again, with the patient present, there is no one size fits all CPT code that describes patient education, patient training, home exercise program. So I think you really just got to ask yourself, what do you train the patient in? What's the purpose? And is it just range of motion, self stretching with their X? Is it focused on the balance, the coordination, the posture? Is that's neuro? Are we tying in functional things to it where it's a therapeutic activity? So I think you just get to make your call.
Yeah, if it's vestibular diagnoses, physiology, anatomy, I will say because that's what they're kind of addressing here, I definitely use 97112 because for me, for them to understand kind of, let's say I'm going to have you do gaze stability exercises. And here's the reason you have a unilateral hypofunction. This is what that means. This is why this exercise is going to help you. This is why you need to commit to it because if you don't do a minimum of 12 minutes a day, the literature says it's not going to help you a whole lot. So
Mhm.
this is where, to me, that wraps up with understanding the diagnosis, the anatomy, and the physiology to understand this is why we're doing this treatment. So, typically that could fall under something 97112, because most of the exercises that I do with my patients for vestibular conditions end up being this kind of more neuro rehab type activity, as an example.
Yeah, and another possibility is self-care. If you're
Yeah.
teaching the patients, maybe modifications of dressing and bending over to put socks on and shoes on, things like that. Because again, another great example, CPT code 97535, self-care home management. PTs are qualified to use that code, whether or not payer pays for it or not. You got to check, but I see PTs doing that for what we're just talking about here today.
Okay. Perfect example. All right. I think this is it. What are the overall top tips you have for effective documentation? I know this is like this really leads into you getting to say how much you have to offer, which is this slide. So, do you have any particular resources you want to point folks to or recommendations to wrap this up?
Am I answering that question? Or am I just talking about myself now?
I would say totally your call. This to me is a lead in
Right.
to
I'll,
what you have to
I'll do the,
offer.
I'll do the quick lead. I'll give you one, then we'll lead into what I do.
Perfect.
When you look at documentation, number one, I think we all do a great job of documenting what the patient did in therapy that day, or maybe what you did for them in therapy that day. What I mean by what you did, the manual stretching, the exercise, etc. But don't forget to document what you are doing for the patient in terms of the verbal instruction, the visual demonstration, the technique correction, the posture correction, your hands-on assist, the progression of the home exercise program, the education training. Because insurances don't care. Helena can do, did 3 sets of 10 of this and 3 sets of 10 of that. Why did it have to be done by you today? So I think we need
Hmm.
to make sure we document that. Number two, I'll give you the billing one. Don't be afraid to bill for what you did. Okay. I know there's a lot of therapists out there that feel guilty because of patient co-insurance and co-pay and all of that. But you got to make money or else you won't be open to take care of those patients. So, you got to bill fairly, but just make sure you bill for what you do. And I'll give you number three. Don't lump everything under therapeutic exercise. Okay. So with insurances that pay on a per CPT code basis, neuro pays more than therapeutic activity, therapeutic exercise. Therapeutic activities pays more than both those codes. You're not billing therapeutic activities because it pays more money. You're billing because that's what you're actually doing. You're not billing neuro over Therex because it pays more money. You're billing because that's what you're actually doing.
Yeah.
So sometimes you can make more money by not working harder, just billing the correct units, which then leads into my last slide here, where I guess talk about myself. So, if you need assistance, looking at your practice, if you're in the red or maybe you're not productive enough or you want to make more money or, you can reach out to me. I do one-on-one consulting via phone, Zoom. I do practice analysis. Also, if you go to my website, you have 3 types of memberships. A gold membership gets you access to all the written content on my website. Platinum gets you what I said, plus 2 webinars I choose every year. And then Diamond gets you what I just said, gets you every webinar I do during your membership year. So I have a lot of information on my website under current news, not just on Medicare, on all the major payers. Check out my frequently asked question topics, where I've got like 25, 26 topics. Where as a member, you get the answers to the most commonly asked questions on all those topics. So that's just a brief synopsis about myself. But again, check out my website and you see what is out there to offer.
That's fantastic. We really, really appreciate your insight on this. Billing can be a tangled web and feel pretty overwhelming. So having some guiding light is so valuable. So thank you everyone for joining us on our journal club. We look forward to having you next time and take care, everyone.
Thank you.